Our next speaker is someone who needs no introduction, but I'm going to introduce him anyway. My good friend and colleague from National Jewish, Chuck Daley.
Thank you, Dave. Let me begin by thanking NTMir. This is an incredible meeting. Every year it gets bigger. It's something that I think we all look forward to every year. I would like to thank the sponsors for making that possible. I think my friend here is our chair for this year. And before we begin this tag team, I have two very important announcements. The first is we're going to not do the Q&A until later, so we'll just pile the morning one so that you can actually get to lunch. The second, which is more important, we have somebody's parking stub that is validated, and we don't know who it belongs to. So you checked in at 8:37. I don't know which car it is, but this will be out at the front desk.
Who validated?
Or you can give me a couple of dollars and I'll give it to you. So anyway, so we are charged with talking about treatment in 30 minutes. That's going to be difficult, but we're going to try to do it, and we're going to approach it this way: who to treat, how to treat, when to treat. And we added the fourth category, why to treat, to the title. I think that was about 10 o'clock last night. I am very happy to tell you I have some disclosures. Research grant and advisory work with INSMED, and as well as serving on advisory boards with the other companies you see here. Thank you to those companies for having something for us to advise about. So who to treat? Took me about 4 hours to figure out how to put that little green dot in there. Okay, who to treat? Well, ATS and IDSA have tried to help us with this. These are what we're often referred to as our diagnostic criteria. It starts with someone having symptoms. So the patient presumably has a cough, fatigue, two of our most common symptoms that we see in our patients, maybe weight loss, but they should have symptoms. And then they should have a radiograph that's consistent with NTM. The top panel you see is a kind of a classic nodular bronchiectatic CT scan with bronchiectasis in the right middle lobe and lingula. And below that, fibrocavitary case, right upper lobe destruction. Either one of these would be consistent. But this is an infectious disease after all, so we need a positive culture. We need bacteriology. And the current diagnostic criteria asks for 2 or more positive sputum cultures or 1 bronchoscopic culture. So this is a guideline. This is all it really is for clinicians, is to try to categorize patients into it's harming them, the NTM, or it's not. But it's not really very well validated and hasn't been until very recently. We've been getting some new studies that tell us what to expect when someone meets this definition. And so I'm going to review 3. So this one by Dr. Wong, almost 500 patients who had MAC pulmonary disease, and they met those ATS criteria, and they followed them. About 63% of them progressed. They had progressive disease. But not everyone did. 24% were stable, and they were stable over a median of about 5 years. So this is an important part of this definition. It's not perfect in predicting who will progress. And then if you take those that were stable and did not get treated, about half of them spontaneously converted their sputum to negative. So this is an important thing for us to understand both as providers and as patients. We need to be able to figure out who's likely to progress and who's likely to be stable. And of those who are stable, half will convert their cultures to negative. Well, this is another study just published. 551 patients with MAC pulmonary disease, also who met ATS criteria. And the numbers are quite remarkably similar. Methodology is a little different, but the idea here was those who the clinician thought needed treatment was about 58%. 41% did not get treatment. So the clinician had to make a decision that they didn't think they need treatment, and exactly how they made that decision is not that clear. But of those that they decided not to treat, about half spontaneously converted. And then the third, Dr. Moon with Dr. Ko with us today, 1,000 patients with NTM pulmonary disease. It was MAC and some abscessus. And again, the numbers are remarkably similar. The clinicians ended up treating about a little over half the patients. About half did not get treated. and 35% of those who did not get treated culture converted. So this definition, while useful, it's not perfect, and we need to better understand what are those factors that result in progression. Well, these studies and some other studies have been trying to look at that, and I'm just displaying them here as those that are, let's call them host or demographic factors, laboratory factors, radiographic factors, which we've heard about, and some microbial factors. So male gender, older age, presence of comorbidities, and low body mass index have shown up in more than one study suggesting these are risk factors for progression. There are some laboratory parameters. Not surprisingly, the more inflamed someone is in terms of their SED rate, their C-reactive protein, if they're anemic or have low protein, these are also risk factors for progression. We heard a lot today about how important the X-ray is, or the CT. Fibrocavitary disease is one of those risk factors, and really just the extent of disease, how many lobes are involved, also can predict progression. And then the microbial factors. This is an area that we're learning more and more about. But if you have a high bacterial load, meaning you have, let's say, a positive smear or multiple positive cultures, that is associated with progression. And even the species that you have. As we know, not all species of NTM cause disease. Some are more pathogenic than others. And we'll probably hear a little bit more about that today. So these are things that a clinician may use to help them determine what to do. So let's say you come to my clinic and I'm looking at you going, you're old, you're young, you're symptomatic, you're asymptomatic, you have a severely extensive radiograph, I have evidence for progression. You know, I'm going to use these things that these studies are showing us. And then I look at you and I go, well, you know, if I had 10 physicians sitting there in front of you and you were like this, we would say definitely treat. Who would we treat? We'd treat this person. Young, symptomatic, cavitary disease, extensive disease. I have evidence for progression. There's no contraindication for treatment, and they have a pathogenic organism. The other side of this coin is maybe I have an older individual who has no symptoms. They have mild radiographic disease. They're stable. They have lots of reasons I may not want to treat because they're taking other drugs with drug interactions. Maybe they've had intolerances, and maybe they have less pathogenic. So these are two bookends. But unfortunately, that's not real. None of us have ever seen those patients before. All of you and all of my patients are somewhere in between. And so we need help figuring out what are predictors for progression so we can determine who to treat. Now, Dr. Ko, Dr. Kwan, and I wrote this chapter, and it was review, and this is kind of the thought process that we go through. And I think it's what most of us use, but we need to refine how we do it. If you start at the top, the patient, they meet ATS criteria, and then we look at that list, those things we know that can be associated with progression. Cavitary is top of the list. Most all of us would treat a patient who had cavitary disease. But if they didn't have cavitary disease, maybe I would use some of these other risk factors for progression to make a decision to initiate treatment then. If not, maybe I'm going to wait and follow this person, have a plan of follow-up, and if they progress, then I would treat. And we'll hear more about that from the issue of progression and how we use that later. All right, that's who to treat. That's how we think about who to treat. How do we treat? This is a 65-year-old Caucasian woman who had M. avium on 2 previous occasions, got standard 3-drug macrolide-based regimen, and is now back with her 3rd episode. This is not an uncommon scenario that we see. This time she's smear positive, so she has a very high bacterial load, and she grew Mycobacterium intracellulare. I don't know that it wasn't speciated in her previous. And what you see is a large cavity, as well as bronchiectasis in 2 focused areas, the lingula and the right middle lobe. So what I need to know now as a clinician to start her therapy, the first and most important question is this. Is that isolate susceptible still to the macrolides? It may not be, because she's been treated twice before with macrolides. And if she is lucky, and it is susceptible, my next question is, does she have cavities? Does she have a cavity? She had a cavity. So if we just follow this down, that means I'm going to start a macrolide-based 3-drug regimen, and I'm going to give it daily. Now, if she hadn't had a cavity, we would consider using 3 times weekly, same drugs, might be some dosage changes, and we would expect to get good outcomes in this approach. Now, if she's not lucky and she had macrolide-resistant disease, we can't use the macrolide. It's not going to provide any antimicrobial activity. So we think about these other drugs, and that list is not very long. And hopefully some of these companies that we're working with now will make this list much longer. But clofazimine, we heard about that earlier today, moxifloxacin, inhaled amikacin. We're now using newer agents like bedaquiline, tadizolid, and even their data now suggesting that dual beta-lactams may have some activity against MAC. For those who have macrolide-resistant disease and or cavitary disease, you may see us say, let's start IV amikacin. That is something that is currently recommended in the guidelines. And our goal in all of these cases is to get 12 months of culture negativity. So this is a recent review looking at 42 studies of patients with pulmonary MAC, 2,700 patients. They define treatment success as you converted your culture to negative and you didn't have a microbiologic recurrence. What they found was about a 53% overall treatment success with this definition. If the patients had received a 3-drug ATS IDSA regimen, about 61% success. And if they took it for at least a year, it climbed to about 66. Now, hidden within there are studies that had 80% success rates. So the success rate with pulmonary MAC, it varies, but this is what the review found by basically averaging. So not everyone is going to culture convert and be cured of their disease. So that's treatment failure and treatment refractory. And what can we do in that case? Well, Dr. Koh showed that if the patient is on intermittent therapy and you switch them to daily therapy, about 30% of those patients will convert. There are other studies looking at addition of repurposed drugs like moxifloxacin, amikacin, clofazimine. About 30% of those patients will convert. And also new drugs like bedaquiline. So almost everything that's been tried seems to increase conversion about 30%. What remains to be seen is what if we did several of these at the same time? Would it go up even more? But the only place where we have clinical trial data to support this number is with the CONVERT study. We heard earlier today about inhaled amikacin, the liposomal variety, or ARIKAYCE. This are the data from the phase 3 study, the CONVERT study. This was a randomized controlled study among people who had refractory disease. And you can see from the study design, patients were randomized to get the inhaled amikacin with standard therapy or just standard therapy. They were treated up to 16 months, and then there was a follow-up. But the key here was the primary endpoint, was looking at the percentage of people who had a negative culture by 6 months. And that's what you see here. So if on the y-axis are the percentage of patients who have a negative culture, the dark bars are those who did get the inhaled liposome inhalation suspension, or ALIS. And as you can see, by the first month, we were seeing separation in the curves. People who were getting ALIS were converting by 1 month, and by 4 months, it was 29 versus 9%, and that was highly statistically significant. The response was occurring in isolates that we used to call resistant, all the way up to MICs of 64. So we learned a lot from this study, and as we heard this morning from our patient panel, this is our first FDA-approved drug. Now, all good things come with side effects, and we also heard that inhaled drugs that we use for bronchiectasis also have side effects. So not surprisingly, most of these are respiratory, things like dysphonia or hoarseness, cough, dyspnea. But most of these have been manageable in practice. We'll stop for a week, maybe some cases of severe 2 weeks, and we reintroduce the drug, and we can usually do that successfully. Because this is an aminoglycoside, it can have ototoxicity, so you can see there's some difference in terms of ringing in the ears and dizziness. Hearing loss, there was no difference between the two arms. Serious adverse events, really no significant difference. And discontinuation of ALIS was in about 17%. So we have this new approved drug, and it is something we are now turning to in our refractory patients. Let me finish with abscessus. This is another one of my patients. Many of you I know knew her. 68-year-old woman with chronic cough and fatigue. Here you see multiple cavities across both lung fields. She grew MAC and then abscessus. We cured her MAC. We never cured her abscessus, despite many years of attempts. And she had eventually a very resistant isolate. And just like with MAC, what really matters the most is the resistance to or susceptibility to the macrolides. So it's a similar story, but the story changes because there's another kind of resistance that occurs in abscessus, and that's called inducible resistance. And it's created by a gene called an ERM gene. And this is a table that was adapted from the British Thoracic Society guidelines. Dr. Howarth and Floto, who were here, I thank you for this. This is a very nice, I think, table. And let me take you from left to right. So if your lab tells you after 3 to 5 days that there's clarithromycin susceptibility, then you wait another 14 days and you look again. And if it's susceptible at the first and the second time point, that tells us, genetically speaking, that the ERM gene that all of these organisms carry must not be working. And that usually means it's going to be subspecies Myceliense. We call it the good abscessus. And that also means this is susceptible to the macrolides, and we're going to give you the macrolide. But there are other scenarios. So one is it's susceptible at the first time point, but is resistant at day 14. Something happened. What we call this is inducible resistance. And that is because this has a functional ERM gene. It is actually working, and in the presence of a macrolide, the organism becomes resistant. It means it's usually abscessus or Belletii, and this is, you can give the macrolide, but you can't count on it as working. The final scenario, which seems the most clear, is when there's resistance at both time points. That's a different kind of resistance. That's called constitutive resistance or mutational resistance, and in this setting, the macrolide will not work. So these are very important issues that our laboratories have to report to the provider so that we can get our patients on an appropriate regimen, but also tell you what to expect. Because based on this one issue of macrolide resistance, whether it's inducible or mutational, will determine how we build the regimen and what to expect outcome. So if you find that there's macrolide resistance, then we can't really use the macrolide or count on it, so we've got to find 2 or more other drugs. We often will pair it with intravenous amikacin. We give it for months, 2 months or more. We don't know the optimum amount of time. And then we often will rotate into what may be a more suppressive or holding regimens. Others skip that part and just do periodic IV therapy with paired oral drugs. What we're hoping for is that there's no macrolide resistance. Now we can use the macrolide. We don't have to look for at least one more oral drug. We still usually give IV amikacin. Whether we need to, we don't know. And so similar approach. We try to go for 12 months of culture negativity, but it's quite difficult with abscessus, so this may not be the most appropriate endpoint. And then these are the drugs that we have. As you see, several of them are intravenous in nature. Some of the newer agents I've already mentioned, bedaquiline, tedizolid, beta-lactamase inhibitors, and even dual beta-lactams, things that are new and things that we'll be trying, and you may hear us talk to you about trying these if you're one of our patients. So why is this important? Because it really matters how you do if that macrolide is resistant or not. So these are 4 small studies. Dr. Koh, who's here with us today, was in that first study. These are small studies, but what they did is they divided abscessus into abscessus or Myceliense. And if you remember, Myceliense is the good abscessus, meaning the macrolide works, and look at the difference in sputum conversion based on that. If they had abscessus, which means macrolide wasn't working, only 25% culture conversion, almost 90% if you could use the macrolide, and it was very consistent across all of these studies. So it's a hugely important thing we have to determine in the laboratory, and it has an impact for our patients. So just to complete, so we just did a systematic review with others here in the room. 14 studies were identified that dealt with the treatment outcomes of M. abscessus. Here we use a slightly different treatment success definition. Basically, it's those people who have culture conversion on therapy. And the treatment success for all abscessus was about 45%, but it was higher in the Myceliense. As I showed you, the numbers in those other studies are much higher, but part of that depends on the definitions used. And also important, we are starting to learn from these studies what might work better. So in this study, in this systematic review, if they got imipenem, if they got azithromycin or parenteral amikacin, patients with abscessus seem to do better. So that's starting to maybe give us some information about which regimens we should start. All right, now we're going to learn when we should do all of this and why we should do all of this. And he does not have a green button, but he can use mine.
Thank you, Chuck. The normal salutation would be, Peter, how are you? With Chuck, it's, Chuck, when are the guidelines coming out? And I thought maybe he would actually change his name to that. But as I think everybody here is aware.
Let me answer that.
Oh,
The guidelines will come out when several of the people in this room give me their comments.
thank you. But the guidelines preparation is a monumental cat herding exercise that's been going on for 4 years.
I don't know.
Whatever. But it looks like the finish line is in sight, and I think we should show Chuck a little bit of love here for being the chair of that committee. The good part about being the last speaker in this session is most of what's in my talk has been covered already. So I'll try to get through this pretty quickly. Whenever we diagnose someone with NTM disease, particularly MAC disease, it's well known that unlike tuberculosis, where the diagnosis requires the initiation of therapy, for our patients with NTM disease, we weigh risks and benefits between the disease and therapy. So this is just a few of those things. You've heard many times that with cavitation, therapy is required. What pathogen is involved, how symptomatic is the patient, what comorbidities do they have, what is the short and long-term prognosis, and of course, what does a patient want to do? So when to treat? Okay, square one, we've heard this over and over. It's very clear fibrocavitary NTM disease from any pathogen is not a benign process and requires therapy. There is no advantage to a period of observation in a patient with fibrocavitary disease. I think we have beaten that horse to death, hopefully this morning. So this is, Chuck, when I was showing him the slides yesterday, said put in an example. So it turns out, just coincidentally, this is one of Dr. Koh's mingled fibrocavitary and bronchiectatic patients. But in this game, cavities trump. So this patient would definitely be considered a cavitary patient. So this is something that's changed in my career. Square two is addressing respiratory comorbidities. And these days, I spend at least as much time with new patients talking about bronchiectasis as I do for NTM disease. And frankly, most of the people that I see who are referred to me have less information about bronchiectasis than they do about NTM disease. Can't pronounce it, can't spell it, and nobody's told them anything about it. So, when we talk about knowledge deficit in the community, I would suggest the knowledge deficit related to bronchiectasis is greater than it is for NTM disease. And I'm going to slander my ID colleagues. Unfortunately, ID folks just don't speak bronchiectasis. And don't always refer people to someone who does. So again, after someone's sent to me with a positive culture for an NTM, the first thing we do is talk about what bronchiectasis is, what it does, and I try to cover as many points as Greg brought up in his talk as I can. Now, there's a couple of reasons for doing that are very important. One of them is this symptom overlap. It's sometimes extremely difficult to know what symptoms are due to bronchiectasis and what symptoms are due to NTM disease. And as you treat NTM disease, bronchiectasis exacerbations are a real pain. As patients have intermittent worsening of cough and sputum production, and again, sometimes it's quite difficult to know what's what. But, for instance, with bronchospasm, Greg mentioned that it's not clear how bronchodilators help in this disease, but there are some patients where it's extremely important. And so in terms of managing someone's quality of life, managing someone's symptoms, this is, in my opinion, for most of our patients, is as important as management decisions about NTM disease. And I hope that we're starting to penetrate the community a little bit better in terms of a knowledge base about bronchiectasis, because as the folks said earlier this morning, bronchiectasis is picked up on a coronary artery CT scan or a gallbladder scan, or it surreptitiously from other places. So we need primary care providers and our other folks not just to recognize it, but to know that you need to do something about it. Just a classic nodular bronchiectatic. I put this slide in just because this was part of a study that we did in conjunction with the folks at the NIH. And the point of this slide is that while patients are being followed for their NTM disease, they have recurrent exacerbations of their bronchiectasis, which really complicates how you evaluate a study drug. So if you've got somebody on medicine and you've got a drug and they happen to be exacerbating from their bronchiectasis on the day that they're in the clinic to have their study drug follow-up, it's not going to look so good on the patient profile or symptomatic profile or evaluation. So again, very important to get someone as close to baseline in terms of the management of this as possible. Chuck's already brought this up, that a lot of folks with nodular bronchiectatic disease, just with initiation of good airway clearance, are going to convert their sputum to AFB culture negative. This is a fair number of folks. I would just put a little plug in for a doc who worked at our place in the 1970s, Dr. Chaeyon, also from Korea. He described the same phenomenon in our patients. The problem was we couldn't diagnose, or not we, I wasn't there at the time, but you couldn't diagnose bronchiectasis, so there was no identification of nodular bronchiectatic patients. But this particular phenomenon goes back some 40, almost 50 years. So when to treat? And I know a lot of you guys have heard this before. There are 3 pillars on which you make this decision. It's the patient's symptoms, microbiologic results, and the radiographic appearance. Just a word or two about microbiologic results. We do put weight on smear positivity and the amount of organisms that are grown in the cultures. That's not everyone believes that. It also depends a lot on what the bug is. So if you have Mycobacterium kinzaceae, which we know is very close to tuberculosis in how it behaves, I'm going to have a really low threshold for starting medicine if you have nodular bronchiectatic disease, because I know that's a pathogenic organism, maybe the most virulent of the NTM. So I'm not going to cut a lot of slack for starting medicines for kinzaceae. Now, even with that bug, there are people who do not require treatment, but you have to be very careful about that. On the other end of the scale is fortuitum. If you've got a dozen positive cultures for fortuitum, I'm still going to be skeptical that it's a problem. And in between, we have bugs like simiae. Do we have get a shout out from anybody from Central Texas here? Okay. Simiae is a bug that we see from San Antonio and in Central Texas, and generally is not a pathogen. But when it is a pathogen, it's a real bear and is really hard to treat. So it takes a lot of scrutiny and clinical judgment on deciding. So for NTM in general, not just MAC, you have to know a little bit about the pathogen in a particular patient to help you decide when you're going to start treatment. And we've talked some about radiographic appearance. So I have kind of adopted what I call the cystic fibrosis model in terms of evaluating particularly MAC patients, which is you identify all potential contributors to the patient's symptoms, you treat all that you can, and then if things are not getting better or they're getting worse, and the NTM is what's left, then that's when you begin therapy. Now, so it's also clear that not everybody who is diagnosed with MAC lung disease needs therapy. As I've just discussed, it's important to optimize therapy of the underlying disease. And it's critically important to continue indefinitely to follow folks prospectively, and for two reasons. One is we have a group of patients who have positive cultures for MAC who don't appear to change clinically, radiographically, symptomatically. And I have patients like that I have followed for years. And then there are folks who we treat successfully, and then we all know that they're at risk for recurrence microbiologically. So in my mind, everybody's a suspect forever, and they have to be followed. So I get pushback here from two sources. One is my patients. So I'm following a nice patient from, let's say, from the Metroplex. They drive 100 miles over to see me in Tyler. And, you know, their cultures are positive. They're doing well. X-ray's not changing. And so I frequently get the question, why am I coming to see you? That's a fair question. And again, it's because there is no statute of limitations. And as Chuck said, we do not have a single predictor of who's going to progress. So we are left with symptoms, radiographs, microbiology. So it doesn't have to be me, and that's what I tell folks. I said, well, you don't have to come to Tyler. We don't have very many good places to eat there. And I'm sure there are a lot of people here nodding their heads there. But I can't predict for you what will happen in the future. I cannot tell you you will remain stable indefinitely. So, and then why to treat? Well, this was just briefly, this was a study we did where we looked at our culture response to therapy, and that people who convert their cultures symptomatically get better. Now, this was not a prospective study. This was retrospective. It only mildly moved the Food and Drug Administration in terms of convincing them that treatment had a symptomatic effect, but we believe that it does. Patients who fail therapy have greater pulmonary function decline than those who are treated successfully. People who are untreated that show evidence of CT scan progression. Microbiologic persistence is also predictive of radiographic progression. So this is not necessarily a benign process. We just don't know exactly how to predict who is going to experience those things, and that, again, is why the follow-up is so important. We've talked a lot about the cavitary disease, and it's very clear mortality is greater with cavitary disease. So this is what we want to avoid. Fortunately, we see less and less of this. In my opinion, this was a patient some years ago who had been treated unsuccessfully and inappropriately and had become macrolide resistant and was essentially untreatable. And the good news is we don't see a lot of folks these days who come to us with this severe severe disease. Not completely gone, but not too many. So why do we treat? Well, hopefully to make people feel better, to avoid pulmonary function decline, to avoid radiographic progression, and hopefully to improve longevity. And I think that's it.